Just published June 4th, 2026, the International Society on Thrombosis and Haemostasis newest consensus statement on management of women with type 2b von Willebrand disease during pregnancy and postpartum. The purpose of this consensus statement is to standardize care, guide management, and improve clinical outcomes for women with type 2b von Willebrand disease, or VWD, during pregnancy and postpartum. In today's rapid update, we'll just be going over a summary of the key guidance statements. So for the full consensus statement, make sure to check it out on guidelinecentral.com. Let's get started. Starting with the section on diagnosis and prenatal counseling. In girls and women with abnormal initial von Willebrand factor, or VWF, tests suggestive of type 2b VWD, the consensus advises that the diagnosis to be established ideally before becoming pregnant. The consensus suggests that type 2b VWD should be considered as a differential diagnosis in all pregnant women with unexplained and progressive thrombocytopenia. In women presenting during pregnancy with suspected type 2b VWD, the consensus advises that the threshold to perform genetic testing may be lower than in the non-pregnant state to minimize misdiagnosis due to pregnancy-induced changes of hemostatic parameters. The consensus advises appropriate prenatal counseling by a multidisciplinary team, or MDT, expert in VWD. The consensus suggests that in women with type 2b VWD, hemoglobin and ferritin levels be checked regularly before and during pregnancy. Iron substitution may be introduced when indicated to avoid iron deficiency and or anemia during pregnancy. The consensus suggests that all women with type 2b VWD are a priority at high risk of bleeding during pregnancy and postpartum, irrespective of previous bleeding history. Next, the section on monitoring and management during pregnancy. When assessing bleeding risk, the consensus suggests that laboratory test results should not be evaluated individually. Combined low VWF levels and thrombocytopenia represents a higher risk than each alone. Thrombocytopathy reported in association with some 2b VWD variants adds to the risk. The consensus suggests that plasma VWF and factor VIII levels and platelet count should be monitored at the beginning of the pregnancy, at least once during the third trimester, close to delivery, and at least once in the first week after delivery. The frequency and timing of testing may be adapted as per clinical judgment. Due to the complexity of type 2b VWD and the high risk of pregnancy-related bleeding events, the consensus advises that labor and delivery should be managed by a MDT in a specialized center with access to factor concentrates and blood products, including platelets. It is important to ensure that hemostasis advice and appropriate laboratory monitoring is readily available to the obstetric team. The consensus suggests that in women with type 2b VWD who experience bleeding requiring VWF replacement therapy during pregnancy, subsequent prophylactic administration of VWF concentrate may be considered. The dosing, intervals of administration, and duration of prophylaxis are determined based on bleeding risk, clinical response, and VWF/factor VIII levels. And last, the section on management of delivery and postpartum care. The consensus advises that a delivery plan should be formulated in the third trimester using a shared decision-making process with the patient and MTD members. The consensus suggests that the mode of delivery mostly depends on obstetric indications. Delivery must be achieved with the least traumatic method to the baby, avoiding fetal blood sampling, fetal scalp monitoring, venous delivery, and mid-cavity forceps. The consensus also advises avoidance of external cephalic version during pregnancy for breech presentation. The consensus suggests that VWF containing concentrate and blood products should be readily available during pregnancy, at the time of delivery, and postpartum for all women with TB VWD. The safe level of VWF and platelet count for neuraxial anesthesia in women with type 2b VWD is not known, and the consensus suggests that the risk must be assessed individually. Intervention must be avoided if the VWF activity level is less than 50 IU per deciliter and or platelet count less than 70 times 10 to the 9th per liter. The trough levels of VWF activity during neuroaxial catheter stay must be greater than 50 IU per deciliter. The removal of the catheter needs approximately the same levels of VWF and platelet count as for its placement. The consensus advises that desmopressin to be avoided in women with type 2B VWD during pregnancy and postpartum due to the risk of causing/worsening thrombocytopenia. The consensus suggests that both laboratory results and clinical scenarios must guide replacement therapy with VWF, factor VIII, and platelets for delivery and postpartum. The consensus suggests that the targeted VWF activity and factor VIII levels for delivery are greater than or equal to 100 IU per deciliter. Trough VWF/factor VIII levels should be kept at greater than or equal to 80 IU per deciliter during the first 3 to 5 days after vaginal delivery and during 5 to 7 days after C-section. Replacement therapy could be continued beyond this period if excessive bleeding or a significant risk of bleeding persists, with an adjustment of treatment according to clinical circumstances. The consensus suggests that platelet transfusion be administered when the platelet count is less than 30 times 10 to the 9th per liter at the start of vaginal delivery, or less than 50 times 10 to the 9th liter in case of cesarean delivery. Repeated platelet transfusions may be needed to achieve counts greater than 30 times 10 to the 9th per liter during the first 3 to 5 days after delivery. If there is excessive bleeding during delivery or postpartum despite correct VWF replacement, the consensus suggests that platelet transfusion be administered to achieve a platelet count greater than 50 times 10 to the 9th per liter. The consensus suggests that blood count, plasma VWF activity, and factor VIII levels should be checked at least once in the first 24 hours after delivery in all women with type 2B VWD. In women receiving VWF and or platelet replacement therapy, levels must be regularly monitored during the entire treatment period. The consensus suggests that women with type 2B VWD undergo individualized venous thromboembolism risk assessment. If pharmacologic thromboprophylaxis is indicated, it should be administered for the minimum necessary duration with close clinical surveillance and appropriate laboratory monitoring of hemostatic parameters. The consensus advises the use of postpartum tranexamic acid according to the ISTH, NHF, WFH 2021 guidelines, which favor administration of tranexamic acid over not. Tranexamic acid may be given via the oral or IV route. The recommended oral dose is 25 milligrams per kilogram 3 times per day for 10 to 14 days or longer if blood loss remains heavy. Women who intend to breastfeed should be provided education about benefits and the safety of tranexamic acid during breastfeeding. In cases of excessive postpartum bleeding, the consensus suggests immediate concurrent hemostatic and obstetric assessment. Hemostatic therapy should be guided by bleeding phenotype and laboratory results, which obstetric evaluation should identify and manage obstetric causes of hemorrhage. After discharge, the consensus advises that the team should keep close contact with the patient until the resolution of lochia. In case of significant bleeding, the patient will need an immediate assessment at the obstetric and hemostasis centers undergoing to rule out/manage obstetric causes of bleeding. If prenatal testing is not done, the consensus suggests that screening for type 2B VWD in the neonate may be done using cord blood sampling. Until the diagnosis of type 2B VWD is excluded, vaccines must be given subcutaneously with the smallest gauge needle. Vitamin K should be given orally if there is the delay in the diagnosis or the diagnosis of type 2B VWD is confirmed. The drug may be also administered subcutaneously if appropriate formulation is available and approved. And there you have it. Make sure to check out the full consensus statement from the International Society on Thrombosis and Haemostasis and other related clinical decision support tools at guidelinecentral.com.